Good afternoon. Welcome to today's Grand Rounds presentation. Please remember to fill out the attendance record, and then also, if you could, please fill out the program evaluation, and if you could give us any ideas in regards to future topics and future speakers, the CME committee would appreciate that. Today, it's my pleasure to introduce a returning speaker. It's Dr. Douglas Hornick. Dr. Hornick is a pulmonologist and professor of medicine at the University of Iowa, where he is also the director of the TB Chest Clinic, the Pulmonology Outpatient Clinic, the Adult CF Clinic, and medical director of the Respiratory Therapy Services. He provided us with a really great grand round several weeks ago on community-acquired pneumonias, and he kindly accepted our invitation to return today and discuss latent tuberculosis. And so please join me in welcoming Dr. Douglas Hornick.
Thank you, Steve. I'm happy to be back and welcome. Sorry if I'm a little bit late, but it looks like I got here in time. You guys haven't eaten too much of your lunch. Some people say I'm a pulmonologist with an infectious attitude. I hope you'll either agree or disagree at the end. But what I do like to do is try to get your involvement in this talk. I want to ask questions throughout, and to get you warmed up, I thought maybe I'd throw this one up. What is this? A picture of whole milk, right? What about this? You guys would probably recognize this. Dr. Pepper, right, I heard somebody whisper that. All right, this one's a little bit harder, and that's kind of the way my questions go. They get a little bit harder with each iteration. What's this? A pool table. Well, you get the hard ones right off the bat. That's very good. But what I'm really going to talk about, besides these silly things, is tuberculosis epidemiology. Really points to the fact that we should be treating LTBI, that's an abbreviation for latent tuberculosis infection, which will be sprinkled throughout. Differentiate LTBI from active TB. I always like to start there and talk about that and make sure we're all on the same page. And understand the latest treatment recommendations for latent tuberculosis. This is an evolving area, something that you may or may not have heard about, a newer treatment regimen that just got discussed and published about 6 months ago in the New England Journal of Medicine. And then I want to talk to you about how new technology actually affects how we approach patients with LTBI. And with new technology comes new abbreviations. How many of you recognize these abbreviations? What's this one stand for? IGRA. All right. Not too many are sure of that. That means we might have something to talk about here. How about QFTG? Some of you have heard of that? Yeah, so the first one is interferon gamma releasing assay, IGRA, and a type of IGRA is the QFTG, quantiferon tuberculosis gold. That's what QFTG stands for. And a newer or not new in the United States, the T-spot.TB test is also a type of IGRA. These we'll talk about during the talk are a blood test that detects tuberculosis and essentially can replace the tuberculin skin test as a diagnostic tool, particularly in latent tuberculosis infection. So also to continue to keep your interest in participating here. I know you guys are professionals. It's always helpful to find out just how professional the group is I'm speaking with. And so I've got 4 of these questions sprinkled throughout. And what I'd like to do is pit this side against this side. All right? So the first question is yours over here. How do you put a giraffe into a refrigerator? Carefully? Right, very good. I can hear you muttering. Cut it up? No, that's a little bit too violent. You actually just open the refrigerator, put it in the giraffe, and close the door. You know, don't make these things overly difficult, all right? I'm not going to ask you too many difficult questions. It's not going to be too complicated as we go along. This slide is a bit complicated, but there's some important points, and it's basically says it at the very top. When you look at the epidemiology of tuberculosis in the United States, it really reflects tuberculosis in the foreign-born coming here from other parts of the world where tuberculosis is much more endemic. The data that supports this includes the proportion of TB cases, active cases, in foreign-born, or being foreign-born, increased from less than a quarter to almost 2/3 across a couple of decades. Last data I have here is 2006. At the same time, basically, the number of US-born people becoming infected or developing active tuberculosis has dropped by almost 50%. MDR-TB, whoops, go back here. MDR-TB, what's MDR-TB stand for? Let's start with that. Multi-drug resistant tuberculosis. What does that mean? I know that means multi-drug resistant, but we do have a specific diagnosis for that. Anybody? So in order to be classified multi-drug resistant, a tuberculous organism has to be resistant to the most important 2 drugs in the regimen. That is isoniazid and rifampin. So at the minimum, any MDR-TB strain is resistant to INH and rifampin. So that's what MDR stands for. And when you look at the cases of MDR-TB in the United States, 3/4 of them about are among the foreign-born coming here and developing their active tuberculosis. We also have to anticipate these other strains, XDR and TDR-TB. What's XDR stand for? Extensively or extremely drug resistant. And that too has a specific definition. So that's an MDR strain. That is a strain that's multi-drug resistant, INH rifampin resistant, but also is resistant to all the first-line drugs, plus quinolones, which are an important part of the second-line drugs, and injectables, the other important part of second-line drugs, things like kanamycin, amikacin, capreomycin. So that's what XDR-TB is, and there have been places in the world where XDR-TB has been identified, and in the United States, and these are becoming more prevalent. We think they are actually more extensive than they have been reported because most of the places where they occur have few resources for detecting susceptibility profile of the organism. So sampling is the only and limited sampling is the only data we have. And just in this past 6 months, a report about TDR tuberculosis, and that is totally drug-resistant tuberculosis. So we're moving back to the future, if you will, in that back before 1940, we had no drugs for tuberculosis. And as we head into this millennium, we're heading towards a time, perhaps, when we have no effective drugs against tuberculosis. Places where tuberculosis arises and those people come here are from Southeast Asia, Sub-Saharan Africa, and Latin Americas. And where they concentrate when they get here are the typical places where immigrants come: New York, northern New Jersey, California, Florida, around Miami area, Illinois, Chicago area, and all along the southern border of Texas in those cities. Active cases most often arise in these people from prior remote infection. And 55% occur, so more than half, within the first few years of them arriving here. It actually breaks down to even greater than that. If you look at the incidence in the first 2 years, it's around 75 per 100,000, and it drops to around 16 per 100,000, and after 5 years, it's around 8 per 100,000 incidents in the foreign-born. So it seems to be a bigger problem when they first arrive here. So actually, let me just ask, because I don't think I have this data until a bit later. What is the overall rate of tuberculosis in this country per 100,000 or incidence? 3. Yeah, it's 3.5. So not very high, okay? And so the foreign-born rate is exceedingly higher. All right, how do rural rates then compare to our national rates? All right, well, we're in Iowa, and pigs are happy in Iowa, and so are we. I'm always happy to be in Iowa, like this pig here. So this is data from the Public Health Department. Actually, the Public Health Department is here today. Alan Lynch and Bridget Kuntz, both from the Iowa Department of Public Health in Des Moines, agreed to come up here and keep me on task and straight on the statistics. And these are just statistics I've gotten from them. And basically, what it shows is that in the green bars, as you can see, non-U.S. exceeds U.S. born in the yellow bars, TB rates in Iowa, just like they do in the national database. So we have the same basic profile in that we have far more foreign-born individuals developing active tuberculosis when they get here than we do native-born developing active tuberculosis. So the U.S. rate I put at the top. Iowa rate is one of the lowest in the country, which is great. But what we see is the foreign-born coming here. And we have a handful, one or less drug-resistant cases. We've had a couple MDR cases over the years. We have one that we're working up currently. The last one was a few years back. So luckily, we've been spared the more difficult to manage, but we still see a fair amount of tuberculosis within our actually concentrated population areas seems to be the common place. Now this time of year, wet t-shirts tend to come up, and statistics about winning those I don't really keep, and maybe you have, but maybe you weren't thinking about this particular wet t-shirt. It happens in the summer sometimes. All right, so let's clarify for everybody, make sure we're all on the same page when we talk about nomenclature that I'm going to be using throughout. So I already mentioned LTBI, latent tuberculosis infection. That is the majority of people infected with the tuberculous organism. And that is somebody who has a positive skin test, or as I mentioned, and we'll talk about, an IGRA test, no symptoms, negative or chronic chest x-ray changes, and these people cannot transmit disease. And this is a question that not uncommonly comes up. So they're infected, but the disease is latent and contained within the reticular endothelial system, so it's not available to be transmitted to others. Active tuberculosis is what everybody fears and is the minority of all people, luckily, infected with tuberculosis. They may have a positive skin test or IGRA, but may not, so certainly high index of suspicion is key. But symptoms are generally present. Chest x-ray and sputum smear are positive in most cases, about 80% of cases. Disease transmission is a risk in these folks, all right, with pulmonary disease. The other thing that sometimes gets confused is we treat both latent and active tuberculosis. We obviously treat them differently, but we treat them both. We don't prevent tuberculosis because, again, that's a misnomer, I think, and I like to point that out. It's a common term used still to treat latent tuberculosis, but you're not preventing infection. You're treating a latent infection. So to look at pathogenesis then on a global scheme, I like this slide because it gives you the impression that what I was trying to show in the previous slide, the latent tuberculosis infection, represented by this big, bold blue arrow, is the majority of cases. The patients at most risk in this group that develop active tuberculosis are those who are infected in the first couple years. About 5% of those develop active disease within the first or second year. Thereafter, the risk of developing active tuberculosis is extremely small and remains that way for the rest of that person's life. And that's how we get to the point that 90% of people infected don't ever develop active tuberculosis. Outcomes then of those infected, just to put this in a final, put this to rest. Again, active disease, a minority of situation, 5%. become active within the first 2 years after becoming infected. They're the ones that are sick and spread disease. The majority have latent tuberculosis. You add these two up, you get 95%. That other 5% are those with latent infection that progress to active disease sometime after that first 2 years throughout the rest of their life. All right? So that's basically latent tuberculosis and active tuberculosis in a nutshell. The focus of TB control then in the United States is targeted testing and treating for latent tuberculosis, the majority of tuberculosis in this country and every place else. If you think about it, what I just told you, it makes a lot of sense based on what I told you about the epidemiology, because we're seeing high rates of TB among foreign-born immigrants to the United States. They come here with their latent tuberculosis infection, so if you have a chance to identify them, you can treat them and prevent them from developing active tuberculosis later. We really see very few cases due to transmission from other active cases. And this has been particularly true since the 1980s, when the HIV epidemic, co-epidemic with tuberculosis, was basically controlled. So the theme of LTBI guidelines is targeted tuberculin testing to find these kinds of individuals. One of the main targets must be foreign-born immigrants from high-incident areas, based on the epidemiology. All right, so we'll get into tuberculin skin testing. Now we'll give this side a chance to answer one of these questions. The public health is off the hook because I think they've heard these questions before. So how do you put an elephant into a refrigerator? You don't. You do. I wouldn't ask about it. Did somebody say something about a giraffe? Yes, so that's exactly right. So you take the giraffe out, then you put the elephant in, all right? You got to think through the repercussions of your previous actions, all right? So keep it simple and think through the repercussions. We got two more, all right? All right, I can tell you're enjoying this a great deal. All right, so targeted tuberculosis testing. Basically, the decision to test the patient means that you've decided a priori to treat that patient if that test turns positive. So these are the three groups who should be tested. Patients at highest risk for progression to active tuberculosis, patients with medical conditions that increase the risk for active tuberculosis, and patients in whom active TB is more prevalent. So we'll walk through these one at a time, starting with the patients at the highest risk for progression to active tuberculosis. So these are those patients. Obviously, HIV infection or risks for HIV, that is, risk behaviors for HIV infection. Close contacts of somebody with infectious tuberculosis, particularly pulmonary and laryngeal tuberculosis, but pulmonary being far more common than laryngeal. New TB infection, so that's somebody who has had a skin test conversion that was negative within the past 2 years and now has turned positive. Somebody with lesions on the chest x-ray that look like prior pulmonary tuberculosis that don't appear to be active. Somebody who's an IV drug abuser who's not HIV, they seem to be a higher risk for developing or progressing to active tuberculosis if they're infected. And then, well, I have a little section on this at the end. Those receiving TNF-alpha antagonists for rheumatoid arthritis or Crohn's also fall into this category. And they may be patients that you guys see out of this whole list pretty commonly. Patients with a medical condition, so the second group is that increase the risk for active tuberculosis. So conditions include bypass surgery, gastric bypass, basically, silicosis, organ transplant, chronic renal failure, tumors, immunosuppressed, substantial weight loss, and diabetes. These are familiar to you. Patients in whom active tuberculosis is more prevalent. These are patients who are recent arrivals, so again, within that window of 5 years from those high incidence tuberculosis areas. People who work in places like this, a hospital, or prisons, jails, nursing homes, and those that work in laboratories where TB is manipulated. Have you heard the one about the two termites that walk into? I'm going to switch gears again. And one asks, what? Is the bartender here? Sorry, I got more punishing The man who walks into a bar with a slab of asphalt on his arm, what does he say to the bartender? A beer, please, and I'll take one for the road. All right, pretty bad. All right, keep my day job. All right, so 56-year-old, there's a case. A 56-year-old woman, asymptomatic, skin test positive. Her husband had tuberculosis 20 years ago. That is active tuberculosis. This is a common thing that I have to tease out in the history. Many patients say, oh yeah, Joe had tuberculosis. And if you ask them more questions, you find out, well, Joe had a positive skin test, never had symptoms, and therefore this individual has no risk for being exposed to tuberculosis because their only exposure was somebody with latent tuberculosis. And that's more common than this scenario, which was really true. This woman had, I'd actually known somebody who treated her husband 20 years ago, and he had active tuberculosis. She was on no drugs, no HIV risk factors, no alcohol risk or use, and her chest x-ray is completely normal. So remember, if the skin test is positive, you always need to check the chest x-ray. So what's the diagnosis? Latent tuberculosis infection, right. So this is where new technology is replacing this old technology. First, the old technology, skin testing. It produces, TB infection produces the delayed type hypersensitivity response, which you measure with the skin test. It detects, the skin test detects LTBI. It's used for contact investigations and looking at persons who have symptoms of active tuberculosis. Although I pointed out earlier, and I'll say it again, the skin test is less reliable in active tuberculosis than something like sputum, a sputum test, which I would go for if I had a choice between the two. When you are administering the skin test, it's an intradermal test. I'm not going to go into detail here. This test here is an example of a positive skin test, which is read at 48 or 72 hours. How do you know this is a positive test? You can tell by looking at it, right? That's a trick question. You have to actually feel it, right? It has to be the induration that you're measuring. And this one has 18 millimeters of induration, which makes it positive. Remember, a positive test can be measured, stays positive for an extended period of time because of the degree of induration most of the time. And you can read it out to 7 days and still, I've been in that situation. A negative test, however, you really have to be around at 48 to 72 hours to read it accurately as truly negative. This is the ballpoint pen method that many of us use to measure the induration. And you record the size in millimeters. All right, so you don't positive or negative, you record the size in millimeters, particularly if it's negative and it has some measure of induration, because next year or the next time, you're going to want to see at least a 10 millimeter change from that original measurement. It takes some training to interpret this, and it also takes spending some time with the patient to understand what it means if they turn up to be positive. This is that list that you usually memorize the night before a quiz or a test, but basically it's not that difficult to interpret the results of a skin test because it's based on your pre-test probability of expecting this to be a positive or infected individual. So the lowest cut point, the 5 millimeters, are those who are most likely to be infected. So you're just going to accept any sort of induration in them. So those are the immunosuppressed, close contacts, children, that sort of thing. 10 is what everybody else gets, all right, basically. And 15 is for those that live in Rhinebeck or Nevada, Iowa, or someplace like that and spent all their years there and never traveled anyplace else. Well, if that person has probably never seen a tuberculin organism, so you really want to put the highest cut point to reduce the chance of false positive interpretation. So that's basically how I go through that particular test. Now, false negatives, there are a whole bunch of things that can cause false negatives in the tuberculin skin test. And I also have a bunch of other limitations listed here, which remind me that the handout that you have today, or that they put together, has all this information. I put far more information in the handout than I'm going to possibly have time to go through. So this is an example of that. If you're interested in reading more about BCG vaccination or the booster phenomenon, it's here in the handout. But that's another problem with the skin test. So I've just had 2 pages here of problems with the skin test. So we've been looking forward to a time when we could get beyond the skin test and find something else. And so with a lot of sweat and ingenuity, just like what we have here in Iowa sometimes, they've actually come up with a blood test that now works fairly reliably. It comes with a new set of issues, which I'll only gloss over as we talk about it here today. But basically, it's the interferon gamma releasing assay, which is the IGRA abbreviation that I talked about at the opening of this, and it's sprinkled through already a couple times. So the QuantiFERON was the first to be commercially available in the United States. And in fact, it always amazes some people in the audience how long this test has been available. It's been available for over 12 or 13 years, yet few people have had a lot of experience. Physicians and practitioners have had a lot of experience with it. It's really become widely used, I think, only in the last 3 or 4 years. Right? And the newest version of the IGRA that's come on the market since 2008 is the T-spot.TB test, which both do the same thing. And this is what happens in the blood test and how it's interpreted. So I'll step you through this slide just so you can have an idea of how the skin test compares to the IGRA test. So here's a diagram of the skin test over here. And as you know, you use a purified protein derivative and inject it intradermally. So that purified protein derivative is from the culture media that they grow tuberculosis in. So it's loaded with a whole broad array of tuberculous antigens, all right? So you stick that intradermally into somebody who's been sensitized, that is infected previously, then the lymphocytes, the T cells, get to that area and they release interferon gamma, and that attracts more lymphocytes and ends up causing the induration that you see underneath the skin. There are other cytokines released as well, but one of the main ones is interferon gamma. And you have to, in order to get that reaction, you have to have sensitized, that is, T cells with a memory. And the only way you have T cells with that memory is that you've been infected with the organism previously. Now, what the IGRA does is it takes that process out of the skin and into the blood tube, or basically into the test tube in the laboratory. And the difference is that you take the cells from the blood, and the biggest difference is you stimulate those white blood cells, those T cells, once you've separated them, with specific antigen for tuberculosis. That is ESAT6, CFP10, and there's now a third one in the assay. These things only are basically derived only from Mycobacterium tuberculosis. Of course, if we could get down to the technicalities, there's some cross-reaction, but not nearly the kind of cross-reaction that is in the purified protein derivative. So these are very specific antigens. They don't cross-react with Mycobacterium bovis, which is the organism that is used for the, or the proteins that are used for the BCG vaccine. So we get away from that particular problem right off the hatch by using these specific antigens. And basically, you incubate these cells in media with the antigens that are derived from tuberculosis, and you measure the release of the signal, interferon gamma, that will signal more lymphocytes to come into the site in the skin, for example. So that's basically how an IGRA works. There's further details. There's control wells. Those of you with a bit of scientist background or are scientists, you'd know you'd need positive and negative controls, and those also affect how the results are interpreted. And again, I won't have time to get into that. I wanted to give you the big picture of what an IGRA test is. This is the T-spot test. A picture of that. Basically, again, it's a nice picture of how the antigens mix with the T cells. They release interferon gamma, and then they use a light releasing assay to actually produce these dots that are then interpreted by the technician. So what I think are important things to know about the interferon gamma releasing assay, these generalizations on this slide here. It's a blood test that's accurate and a reality that can substitute for the tuberculin skin test. And I'll say at the top, the best place to use it is in those people who have had a BCG vaccine previously. That's where the data is the strongest for the value of this particular test. We have the T-spot test and the QuantiFERON TB Gold. They're commercially available. They measure interferon gamma, as I talked about. They don't cross-react with non-tuberculous mycobacterium as well as bovis or BCG. Advantages, patients in whom a false positive skin test, that's where you'd use it, those with BCG. A follow-up is not necessary, so the patient doesn't have to come back at 48 and 72 hours to have the test read. You call them up on the phone, give them the results, and then decide what to do with them. It has equal sensitivity to the skin test, but much greater specificity compared to the skin test. The biggest limitation that is partially overcome now is that the lymphocytes have to be fresh. That is, out of the body and used within 12 hours. All right, so you can't mail this blood someplace else to another lab to do it. Now, the QuantiFERON company has come up with an in-tube test that requires an on-site manipulation overnight in an incubator, basically, and then it's good for 3 days. So that is a sort of workaround for this requirement of getting the lymphocytes fresh. The other important point, just like the skin test, is that the IGRA, just like the skin test, won't tell you whether this patient has latent or active disease. It tells you they're infected with tuberculosis. Your job is then to decide whether they have active or latent tuberculosis. And how do you do that? What's the simple way that you do that? Chest x-ray, right. So after you get a positive test, you get the chest x-ray. All right? Here's another sort of data slide for your use to read later. Again, just like the skin test, there are operational characteristics that make interpretation a little bit difficult at times with the IGRA, and we're still getting to know those. So these are listed on this slide, and I'd be happy to answer specific questions about those afterwards if there's time. There are some key references here that are recent updates on the use of these two tests, and the CDC has basically put a consensus guideline, which is the top one there, and I think that it's probably useful to have that if you're going to be using this test any time soon or routinely. So when you're screening, then what I've kind of walked through partially already, talking about that case, the 50-some-year-old woman who was a wife of a former active tuberculosis case. So this person was at risk. We did a skin test. She had no symptoms. The skin test was positive. The chest x-ray was normal. So this person is a potential candidate for treatment of latent tuberculosis. If the chest x-ray was abnormal, you'd have to do further checking to rule out active tuberculosis. All right? So, oh, that just reminds me, I hope that chart wasn't too complicated. Here's an engineering flow chart. I love the way engineers think. It's just yes or no. Does it move? No. Should it? No, no problem. But if it should, you WD-40. If it's supposed to move, and or it's not supposed to move, and should it not move, then you use our favorite duct tape. There you're done. That's an engineer's life. I wish in medicine, a lot of us probably started out in engineering, thought things should be more complicated, so that's why we moved to medicine. No, I have nothing against engineers. I think they have just as complicated life as we are. So back to the case. So we obtained the skin test. The chest x-ray was negative. So do you need a sputum? Wasn't in the flow chart. Right. Only if you're suspicious for active disease. Again, if there was something on the chest x-ray. This is a reason why I just hit on this again is sometimes this happens where somebody's gone through this paradigm, negative chest x-ray, they submit sputum for just to be careful and complete, and 3 or 4 or 5 weeks later they get a call from the lab. Dr. Jones, that sputum on Mrs. Jones is now growing mycobacterium. What do you want to do? Don't panic, okay? What's the most common isolate in that particular situation? Is it tuberculosis? No. It's the most common isolate in every mycobacterial lab, 10 to 1, compared to Mycobacterium tuberculosis. That's Mycobacterium godonae. Mycobacterium godonae is a non-pathogen which lives in the environment. It lives in very difficult environments with most other bacteria can't live, and so somehow it sometimes gets introduced into the process of the specimens, and then it grows up under those conditions. So the point of that particular scenario is wait till they tell you what they identified. So don't react, because you can imagine then you go and call the patient, you call the family, you say, oh dear, we got active tuberculosis. You bring them all in. Then the next day, the lab says, oh, good news, it's Mycobacterium godonae. Now you've made everybody upset because you've got public health all over these people. And so wait till you get identification if you were never suspecting that this patient had active tuberculosis. But the bottom line is, they're a negative chest x-ray, don't get that sputum. All right, so what's the treatment for this patient with latent tuberculosis? INH, for how long? 9 months or 6 months. So these are the guidelines for this. 9-month regimen represents reinterpretation of old data, not a failure of the previously recommended 6-month regimen. So we usually try to get the patient to get 9 months. The reason for the differential in interpretation is basically from these Bethel data that were published way back in the 1960s. It's the best data we have about the different lengths of treatment for LTBI. And there is a breakpoint somewhere between 6 and 9 months where more drug won't make any difference in terms of reducing the rate of active tuberculosis subsequently. You see, you reduce the rate from around 5%, which is what would be predicted, to somewhere around 1% with LTBI treatment. So 6 to 9 months is probably good. Longer is not any greater. So that's basically why we say that. INH for 9 months or 6 months. Rifampin for 4 months can be an alternative. Again, I'm whipping through this because I know we're getting close to the end, and I think most of you understand this data. What I wanted to do, of course, is get to this next question here, see how professional you are. This side, right? The Lion King is hosting an animal conference. All the animals attend except one. Which one is that? Well, you guys are getting good. Why? Because the elephant's in the refrigerator. All right, you guys got memories like an elephant. All right, one more. You're doing good. All right. Well, just like with diagnosis, we now have new treatments for latent tuberculosis. And this came out in the New England Journal of Medicine just at the end of last year. And this new regimen is this. I knew this was happening. INH for 900 milligrams, standard dose for daily therapy is 300 milligrams, so it's a high dose with rifapentine, which is a long-acting rifamycin, so it's a derivative of rifampin, but acts for an extended period of time. So 900 milligrams of each of those drugs once a week for 12 doses, or basically 3 months. All right? So we've reduced it from 9 months to 6 months to 3 months. All right? So this data in this study was an open-label, randomized, non-inferiority trial. And so it was done like most drug trials are done these days to prove that the new therapy isn't worse than the old therapy. It's not a head-to-head comparison. But it was very interesting that the outcome, even though it was set up this way, the outcome made the new therapy really actually look a little bit better than the standard therapy. So the way it was designed in more detail is here. The new regimen was done by DOT, so you're telling people to take these drugs once a week for 9 doses or 12 doses for 3 months. So again, you have to basically supervise that. You can imagine what happens if you're trying to put people on their own to do this on their own. This is a large multi-country international trial done in the United States and Canada. Was followed out to 33 months. They did include a few patients with HIV and children, which was good because this means that we can apply this across a broader population. And they picked people who are more likely to develop active tuberculosis in the shorter period of time so that they really could see that endpoint. So the new converters of skin tests and people with old healed TB chest x-rays, so these are people that are more likely to develop active disease in a short period of time. And the results was it was non-inferior or equivalent to the 9 months. And basically 9 months was given to the patient, and they were told to take it and come back every month and double check that they've been taking it. So the adverse events were no different, basically. There was slightly more hypersensitivity in the dual regimen versus the hepatotoxicity that we generally see in the INH regimen. So like I mentioned, the trend was towards better in the new regimen. The TB rate was 50% lower. Treatment completion rate was better by a substantial amount, 82% versus 69%. And this is the way it sort of played out when you look at this non-inferiority graph, basically where non-inferiority margin would be way up here and favoring the combination actually drops below 0, and you can see it was just within the confidence limit and towards actually favoring the combination. So that's why we think that this might be a fairly decent regimen, actually slightly better, certainly equal to INH. And again, it was done in 8,000 patients, so a pretty powerful study. Now, this is the real-world recommendations that come out of this, and this is partly why I have the Public Health Department here, because they might be able to answer some more questions about this if you want to talk to them afterwards. So the bottom line is this therapy does not replace the standard therapy, but it's felt to be equal. The Public Health Department provides 9 months of INH at no cost to the patient, right? Plus monthly supervision. That is, every month the patient brings the medications back, or the empty bottle back, and they get another 30 days. They get a symptom review to make sure they're not having symptoms of liver or other toxicity. So you get a pretty well-monitored 9-month regimen. And again, it's not at any cost to the patient. The unfortunate thing is that the new regimen is not supported by the Public Health Department because the Public Health Department, as you know, in this climate, is not getting a whole lot of extra money for anything. And this new regimen costs 10 times what it does to do what I just described, to give 9 months of INH. So we would have to, they just would bankrupt the department. So they can't cover the cost. But if you want to use the new regimen, you're welcome to. But we strongly recommend you do it with DOT. The patient pays for the medication just like they would for anybody else, for any other treatment. But you should make sure that they come every month to get that medication at your office or some reliable site so that you can make sure that they complete the regimen. And again, look for signs of toxicity. It's not recommended for certain situations that are pretty obvious and they weren't studied within that clinical trial. All right. So this particular patient got 9 months of INH. Public Health Department did it, and she completed the therapy within 9 months as anticipated without any complications. And actually, this is a pretty old, I still see her every once in a while. It's been more than 10 years or so, and she's still doing fine. So One more question. You guys ready over here? How professional are you? There's a river that you must cross, but it's inhabited by crocodiles. How do you manage it? There's no bridge. And you're on the wrong side. I like your enthusiasm, though. No, you can't bring the elephant back. Right? Because the elephant, just like everybody else, is in the crocodiles too, or at that animal meeting that the Lion King called. All right? So you need to swim across. All right? All right. Interestingly, Anderson Consulting, who put this together, said 90% of professionals tested got all questions wrong. Many preschoolers got several questions right. You draw your own conclusions. All right. So, summary here at this point, and I think it's 1 o'clock. Screen persons at risk for tuberculosis, particularly the foreign-born. You have to distinguish active for latent tuberculosis, understand that difference. LTBI, skin test positive and treatment reviewed. The importance of making the decision to test means you're making the decision to treat that person. You want to clinically monitor. I have all that stuff in the subsequent slides that I haven't gone over. I have some drug toxicity information that, again, I didn't go over in details. I hope you did understand better now, do understand better, the IGRA, QFT, and the T-spot test. Public Health Department is very supportive at treating these patients with LTBI at no cost. And the problematic exception is the new regimen. And you can call the Public Health Department with any TB question, or when you suspect a patient may be infected with a drug-resistant form of tuberculosis, and that's why, and they have LTBI. At this point, I want to just ask you one more question. What's this? Tap dancers? Okay. This is the monitoring part that I talked about. I'm just going to walk you through the rest of it. And the case examples, immunosuppressed. I'm not going to have time. The TNF-alpha part is right here with clear guidelines in there, so you can look at that later if you want. A couple more cases, and then basically I think it's always time to take time to smile. I appreciate your smiling, including my dog. And I think we're at the end. Thanks. We do have time for questions, it looks like. All right?
Thank you very much for the excellent talk. I'm going to ask you to kindly overemphasize. I don't think we can overemphasize this enough. The most common question that comes across, which is BCG effect on the PPD. And I think you touched base on this, and it's certainly in your slides, in lack of the same in the quantiferon, and when the supposed effect on the PPD wears off, and so forth.
Okay. Do you want me to answer that, or you're making a statement? Basically, what you're saying.
I'm going to ask you to.
Yeah. All right. So when it comes to BCG, the majority of people that have received BCG that come to testing have been living in previously an area of the world where tuberculosis is highly endemic. There are exceptions, England, Canada, but they don't do BCG very often in those places anymore. So, so that's one point. So they're from a high incidence area. So when they have a positive skin test, epidemiologically, it seems the data proves that they're more likely positive skin tests because they're infected with TB rather than that prior BCG vaccination. So if that's the only option you have in that individual, you should consider that skin test as positive, reflecting latent tuberculosis regardless of the BCG status previously. That's a simple, straightforward interpretation. Again, I have more data in the slides. Now, you can get around that by skipping the skin test and in that kind of individual and just go right to the blood test, because there, your response, that response to the blood test is not at all going to be influenced by the immunity of the prior BCG vaccination. So to me, that's probably the most, that's what I do when I'm faced with that scenario. Most of the time, though, that person's coming to me because they've had a skin test and they think that it's falsely positive because of the BCG. Then, of course, you can use the IGRA as your tiebreaker. I would warn you, though, of some other operational characteristics of the IGRA that have come to light recently, and that is that if someone's had a skin test recently, that can falsely influence the results of the IGRA test. So unless you draw the blood at the moment you read the test at 72 hours or 48 hours after applying that skin test, draw the blood at that point, yes, it's reliable. But for the next 3 months, it probably, if it's positive, it could have been the skin test, or it could be that person was infected. If you're beyond 3 months from that skin test, then whatever that IGRA test shows is probably what I would use as the final determination. I hope that last part didn't confuse anybody. All the point is, you don't want to do those two tests, one right after the other. If you're going to do the two, I wouldn't do the IGRA, then the skin test. If you're going to do the IGRA, just do the IGRA. If you can avoid, and if you're just going to do the skin test, just do the skin test. You get into trouble when you start mixing the two and trying to interpret the two. But what I just described to you was a way to maneuver through that fairly reliably. A little long answer, but I think it gets at some of the points in your question. Yes?
Yesterday I saw a horrifying story, a woman who had a negative quantiferon gold test and caseating or non-caseating granulomas in her chest, and ultimately they grew out tuberculosis, but she was treated for sarcoidosis for a while. Sensitivity, specificity on the quantiferon gold test?
Well, that brings up a point, and I just glossed over it in the discussion. So just like the skin test, if you're suspecting active tuberculosis, that patient may not be able to mount enough of an immune response or hypersensitivity response to either convert the skin test and even enough to be measured in the IGRA. So you can get tuberculosis-specific energy in acute infection in TB with the skin test and with the IGRA. So again, if you are trying to work up somebody with active tuberculosis, I usually skip the IGRA and the skin test and go for more reliable things like the biopsy, like a sputum if they've got active disease, something like that. And the IGRA, if it comes back positive, yes, it helps you. But if it's negative and you have a high suspicion of active tuberculosis or tuberculosis is in your list, I think you can't remove it if you have a negative IGRA test completely, unless you have a better alternative diagnosis.
And last quick thing, the longest axis of the positive PPD, is that what you're reading?
Yes.
Okay.
For the, yeah. Other questions? Thank you.